Great. Go the other side. Yes. For me.
Good morning, everyone. Welcome to the Pediatric Grand Round at Nicholas Children's Hospital. It's a pleasure to introduce our speakers this morning, Dr. Otto Ramos. Dr. Ramos is the director of the Division of Infectious Diseases at Nicholas Children's Hospital, and he is also the Nicholas Children's Pediatric Specialist Chief Section of Pediatric Infectious Diseases. Dr. Ramos served also as an epidemiologist and medical director for the virus lab at Nicholas. He also served as a chairman of the Infection Control Committee since 1984. Dr. Ramos earned his medical degree from the University of Santiago in Spain, followed by postgraduate training at the University Hospital in Jacksonville, Florida. He then completed his pediatric residencies at Jackson Memorial Hospital and Driscoll Children's Hospital, along with a fellowship in pediatric infectious diseases at the University of Texas Medical School. His clinical interests include rapid diagnosis of viral infections and treatment of immunocompromised patients. Dr. Ramos is board certified in general pediatrics and pediatric infectious diseases. He is the author of numerous articles, has presented at national and global medical conferences. Dr. Carolina Sanchez-Vegas. Dr. Sanchez-Vegas earned her medical degree from the Universidad Central de Venezuela. She then completed her pediatric residency here at Nicholas Children's Hospital, and this was followed by an infectious disease fellowship at Boston University Medical Center. She then joined the Division of Infectious Diseases at Nicholas Children's Hospital in 2009. We were lucky to have her come back and join us. She is board certified in pediatrics and pediatric infectious diseases, and she is also certified in travel health. Their topic this morning is obviously very timely for everyone around the globe. COVID-19 vaccines and treatment updates, dispelling the myth. No relevant financial relationships or conflict of interest were disclosed by neither speakers. Dr. Ramos will discuss the unapproved Oxford and the Johnson & Johnson COVID-19 vaccines that have been not approved yet, that pending approval. And Dr. Sanchez-Vegas will discuss various unapproved off-label use of COVID-19 treatments, including ivermectin, vitamin D, monoclonal antibodies, hydroxychloroquine, and others. Please help me welcome Dr. Ramos and Dr. Sanchez-Vegas.
Thank you. Thank you very much, Rani. Good morning, all. We want to talk a little bit about prevention of SARS. I have never before spoken on a subject that changes almost hour to hour. You know, the situation with vaccines, everybody's aware of. We were doing well at the beginning of the month. And then for the last week or so, we've not had enough vaccines. I hear that we may be getting a shipment next week. So whoever on the medical staff has not been vaccinated, it's going to be a tremendous opportunity. I would do it as soon as possible. So we want to talk about, in general, people believe that this disease does not have an impact in pediatrics. This is completely wrong. If you look at the numbers, as of last week, we had seen 4,798 unique cases. If you add anywhere between 20 to 40 per day, you know, we're well over 5,000 cases that have been diagnosed by this institution. Out of those last week, we had hospitalized 479 patients, and out of these, our length of stay was 4.28 days. The treatment that we use occasionally when it's indicated, remdesivir, takes 5 days. So there are patients that just get admitted, get observed for a couple of days. If they're better, they go home without treatment. If they need treatment, then they usually stay about 5 days. Out of the patients that we admitted, 101 were admitted to the ICU. This number is a little bit bigger. There are several patients there right now. And we had 9 patients intubated and in respiratory failure. So the numbers in pediatrics are very significant, I would say. There are several vaccines, as you know. Companies around the world are working on about 170, and they're all different vaccines, 170 different vaccines. So do we have a need for so many vaccines? Probably not. Probably we're going to end up using a number of them, but certainly not that number. The ones that were kind of ahead of the game and were approved by emergency authorization fairly early in the game were 2 vaccines, and both of them represent a completely new technology in vaccinology. They are the mRNA vaccines. And there's one made by Pfizer that was approved early on, and then it was followed by Moderna. By far, most patients have gotten Pfizer, and all of our patients and all of our staff has been immunized with Pfizer because that is the vaccine that we got. As you know, Pfizer, you need a booster at 21 days, and with Moderna at 28 days. There has been a lot of talk about changing this. For example, in England, they decided that it was better to just give one shot and forget about the second one to vaccinate as many people as possible. Most virologists in the United States will advise against that because the studies were done the way that the vaccines are recommended. Not, we think that you could possibly, if you had to, you could delay the booster, but we don't know for how long. The longer that you delay it, the more chances that the vaccine may not be as effective. This technology came out, and a lot of people say, well, this is a new thing. I'm not going to be a guinea pig. I'm not going to allow a vaccine that hasn't been proven and so forth. Actually, scientists in the United States have been working in this type of vaccine for 30 years. So it's not, it is a new vaccine in the marketplace. It is not new technology. A molecular biologist at the University of Pennsylvania, a very smart scientist by the name of Katalin Kariko, developed the technology. She worked 30 years exclusively on mRNA technology. She's a Hungarian immigrant, and her research was not going well. In 1995, she was demoted, and she could not get any grant for her work. And next time that we run into Dr. Fauci, we should ask him why he didn't fund this research properly. Because in my opinion, this is not going to be only for coronavirus, but in the future, this technology may be used for many other vaccines. She's presently doing very well. She's vice president of research at BioNTech, which is the company that developed the Pfizer vaccine. And she actually ran into a problem that every time that she injected RNA, that it would be destroyed, that it would not, the immune system would be activated and it wouldn't work. It couldn't penetrate the cell because it would be destroyed by the immune system. She got help by another very smart man, Dr. Drew Weissman, and they discovered that there was one single nucleoside that was throwing everything off. And they changed that. They changed that nucleoside. Now, the way that I think about the way the scientists can change genes and nucleosides and so forth is the same way that your kids play with Legos. You know, they don't like one Lego, they take the block out and they put another one. And this is what is done in viral immunology at this time. They created a hybrid messenger RNA that could penetrate into the cells without alerting the immune system. Now, the problem that they have is messenger RNA is very unstable. We have enzymes called RNases. They're everywhere, and they break out RNA very quickly. Another company based in the United States found that you could develop a lipid capsule This lipid capsule is called nanoparticle. And you could put that messenger RNA into the nanoparticle, and the nanoparticle would protect it. So this is the reason why the vaccine needs to be kept at freezing temperatures, because if you don't do that, that lipid capsule will deteriorate and the RNA will be inactivated. So it's one of the problems with the Pfizer vaccine, that it has to be kept at very low temperatures, -72, and then the Moderna vaccine also, but not as much. You could keep it in a regular freezer. Actually, you don't need the special freezers. Even when things are working 100%, this messenger RNA will be completely degraded in 2 weeks. You won't have it anymore. It's not going to hang around in your body for 30 years. It's not going to cause cancer. It's not going to cause anything. It's going to be gone in 2 weeks, and it will have done its job in 2 weeks. Messenger RNA actually gets into the cells, never goes into the nucleus. It works at the level of the ribosomes. And it tells the ribosomes, you need to make spike protein. And the ribosomes start making spike protein like crazy. And all of that will go into the circulation. And then your immune system will take over and destroy that spike protein. Therefore, when you get an actual exposure to the virus will not be able to attach to the cells, because your antibodies will destroy it. Your antibodies will inactivate it. These are non-replicating RNAs that is used. It should not be confused. There is self-amplifying RNA available in technology. It's never been used in infectious diseases. The thinking is that you could use it for the treatment of some tumors. So the one that we're getting is a non-replicating messenger RNA. It doesn't hang around, it goes away. So you don't have to worry about it. Messenger RNA is not obtained from the virus at all. It's 100% obtained in the lab. It's not attenuated or kill virus at all. What they did is they made a DNA template. They added RNA polymerase, which is an enzyme, and then it makes a mirror image of the original DNA, and all of a sudden, you got messenger RNA. Messenger RNA that is able to direct your cells to make spike protein. Nowadays, scientists are able to replicate and modify any molecule without using the original virus. So we've always known that viruses undergo constant mutations. Initially, when we started dealing with coronavirus, a lot of the virologists said, well, this is really very slow to mutate. You don't have to worry about new mutations too much because it's going to take a long time. And of course, at that time, everybody thought that this was going to be short, that we're not going to have this virus around for as long as we have had. What happens is that, and in South Africa, they have looked at this very carefully. The virus has a new mutation or 2 mutations per month. So it does mutate. So there are multiple variants now that have been documented in the United States and globally. In the United Kingdom, there is a new strain known as B117 lineage. And these emerge with multiple mutations, about 10 mutations, and they're all located at the spike protein, which makes transmission more efficient. So this is a virus that is transmitted more efficiently than the original one. And you could say, well, that's, United Kingdom, not here in the United States. Well, in the last couple of weeks, they started doing sequencing more intensively because they realized that we had a problem. And we have found that Florida has a significant amount. And in fact, South Florida, they have only up until now identified 92 cases, but obviously the amount of detection that they have tried is being very limited. So it is probably here at a significant amount, and it could replace current strains. In South Africa, they had another variant. This one is known as B1351 lineage. And this one took over. In fact, in the latest study in South Africa, 93% of the cases were caused by this new variant. And it already spread to African countries that are around South Africa and also to European countries. If you read last night, the internet, it was published that there were 2 cases that had not traveled to South Africa and had nothing to do with one another, were different people and not related in any way. And both of them were positive in South Carolina. Both variants, we believe, can be neutralized by the current vaccines to a certain extent. We know that the vaccine is much more efficient against the B117, and perhaps not so much unless you have very high antibody titers to the B1351 lineage. Now, the companies are already getting ready to change, and they can modify their vaccines very quickly. It is not going to be a problem for them. Of course, they have to do studies. Of course, it has to be proven, but they are already working on it. So this is the virus itself, and it only has 5 proteins that are the ones that we call structural proteins. And when you look at the spikes, you know, you look at what we call the area of the spike protein. This is the binding region, and this is where all these mutations are taking place. The vaccines that we use, most of them, the newer vaccines, they all look at inhibiting or changing somehow the spike protein so that it is not efficient in attaching and fusing into the cells. Now, if you take a whole virus vaccine, which, you know, for example, India has, then it's going to be geared to almost everything. But this is the extremely important area, and this is what it has changed. And actually, the South African variant, there is 23 different mutations just in this area here, which is, you know, the binding region. Brazil also detected a new variant, and this happened a couple of weeks ago. There were 4 people that traveled to Japan, and the Japanese, that they're excellent at doing this, they found them to be positive. They did sequencing, and they found that it was a new variant, and this one is B11248. And then some people said that in the Amazon, this has been circulating since July of 2020. So it may not be a new variant, it's just that it was recently discovered. We don't have too much information about this virus. We don't know about neutralization with the vaccine and so forth. But if we do not get vaccinated and we don't eliminate these strains, we're going to be dealing with this for years. These new variants bring up the possibility that if you have had COVID already and you had it with the standard strains that happen in the United States, which is what they call the Italian strains, you could possibly in the future be reinfected with the new strains. So the actual antibody production of the vaccines is better than natural disease, especially if you had mild COVID. You may not be protected. You may have very low antibody titers. Since no vaccine that we have is 100% effective, the best way to prevent it is to build a firewall by vaccinating everyone around you. That is going to be the most effective. When we have natural infection, we don't develop one type of antibody. We actually develop thousands of different antibodies to whatever epitopes they can find. You know, that includes the structural proteins that we showed, you know, the nucleocapsid and the spike protein and everything, but also to other different non-structural proteins. But when you're talking about the vaccines that we have available right now, most of the antibodies are made against the spike protein. More recently, they have discovered new small molecules called nanobodies. And these are actually more efficient than antibodies. They're smaller, they're able to penetrate the cell better, and they attack the S protein and they modify it permanently in a way that the virus will not be able to bind. And also our lymphocytes, our CD4 and CD8 will develop specific immunity that is probably longer lasting than antibodies. There's a couple of vaccines that are going to be available very soon. There was a vaccine that was developed in England, and it's the so-called Oxford AstraZeneca vaccine. It is already in use in the United Kingdom. It was developed there. They also did trials in Brazil, and they also did trials in South Africa. What they did is they took a chimpanzee adenovirus as a vector. And why did they take a chimpanzee adenovirus? Because we don't have antibodies against it. And if they give you an adenovirus that you already have antibodies against it, it may interfere and your immunity may not be perfect. So they took something that we had never seen before and they added a piece of the spike antigen, something that it was genetically engineered, something completely recombinant. They added it. So that's why I'm saying it's very simple for them to modify that spike protein for the new variants. And this vaccine requires 2 doses, 28 days apart. And it's going to be a little bit of a problem, but of course, the company has done a lot more research, but initially they made a mistake and a good number of the patients only received half of the intended dose by mistake. The combined efficacy was reported to be 70%, but it was actually higher in the ones that got the low dose, standard dose cohort. It was 90%. So it was somewhat similar to the 95% or 94% reported with the prior vaccines. There was some short-term protection with 1 dose, and the efficacy was lower against a symptomatic infection. One of the problems for licensing in the United States is only 12% of the patients were older than 55 years of age. I am sure that is going to be submitted perhaps as early as March, and I am sure that they now have enough data to support it. The other vaccine is Johnson & Johnson. It's also a recombinant. It uses an adenovirus 26. Now, this is a human adenovirus, but we don't, it's not an adenovirus that circulates very often. Most of us don't have antibodies against it. And they added the full length of the spike protein. They were very careful about adding every possible piece of that spike protein, including the capsule, so that it would be well represented. After a single dose, antibodies were detected over 90% of the patients, and this was regardless of the age group. Now, when you looked at the people between 18 and 55, 100% develop antibodies. Still, after 71 days post-vaccine, the antibody titers were increasing and had stabilized. They also looked at 2-dose administration, and you do get higher antibodies. The thing is that it is not known whether that increase in titers after a second vaccine will provide additional benefits or not. And just the last thing that I want to show you is what has happened with COVID, because some people, you hear that there's a lot of it or less. People have been telling me the last 2 or 3 days there are less cases. Look at how it has gone. This is up until January 18th. And, very high number of cases. The incidence has been increasing, and if these new variants take hold, then you can expect more cases. So, the whole idea is get vaccinated. There is a lot of stuff going on in the internet that has been actually initiated by even foreign countries. They do want to trash some of the American vaccines or the European vaccines. Do not listen to that. The vaccines are very solid. They have been given to over 40 million people. The number of side effects are very low. You know, in terms of number one would be severe allergic reactions. That happens in 1.1 per 100,000. So you don't expect to be that person 1 in 100,000 anyway. But precautions are taken. EpiPens are available. Treatment for anaphylaxis is available at the places that the vaccines are given. With that, I'm going to give the floor to Dr. Sanchez Vega, who will expand on this talk.
Great. While Dr. Sanchez Vegas is sharing her screen, she's going to talk about the treatments as well and some of the myth behind them. I see some questions in the chat. We will do question and answers at the end after both speakers finish. Thank you.
Hello, everyone. Good morning. Thank you, Dr. Ramos. That was an excellent presentation. So today, my goal is not to give a comprehensive talk on the management of COVID-19, but rather to talk about some of the therapies that have come out in the last year or so, or since the pandemic started, and some of the evidence behind the use or against the use of these therapies. And okay, and so this is the list of what I'm going to talk about today. Is obviously not a full list of everything that's out there, but I think it was the more relevant and the more that I think they're more important, and also the more I get questions about. And I think the big question we always get is to give or not to give. So first, to understand the way or when to use these medications, or when will they have the effect, you have to think about the pathogenesis of the virus. And we do know that early in the disease, it's the pathogenesis is primarily driven by the replication of the virus. And then later is more driven by an exaggerated immune inflammatory response to the virus that leads to tissue damage. So based on this premise, then you're going to know that probably antivirals will work better early on in the disease, and then anti-inflammatories or immune modulators will work better later on in the disease. Just a review on the clinical spectrum, we know that there's a large percentage that presents with asymptomatic or pre-symptomatic infection. They have just a positive test. Then the mild illness, where there's fever, chills, cough, sore throat, but a malaise, but there's no shortness of breath, dyspnea, or abnormal chest imaging. Those considered moderate illness, there is evidence of lower respiratory disease, either by a physical exam or in imaging, but their O2 sats are above 94% in room air, or there's no increase in their baseline O2 requirements. Severe illness are defined as the ones that have a saturation of less than 94% in room air, or increase in their baseline requirements. They're tachypnic, or they have more than 50% of lung infiltrates on the imaging. And then critical illness is defined by respiratory failure, septic shock, and or multi-organ dysfunction. So most of my evidence or my presentation is based on the guidelines published by the NIH, and I invite all of you to review these. They're constantly updating it, sometimes weekly. So most of the evidence is coming from there. So first I want to start with the basics. NSAID. So early on, there was anecdotal report of negative effect in patients with COVID. There were a few reports of young individuals that used NSAIDs early on the course of the disease, and then ended up having a more severe disease. There was a South Korea study that they view hospitalized patients who had taken NSAIDs the week before hospitalization compares to the ones that had not, and then those had more severe disease. But there was some confounders in the study because they were the ones that had taken NSAIDs ended up being more patients with older or with more comorbid conditions. So the clinical data is limited. Many studies have shown that there's no association. And at this time, the NIH, they say that those people that are already taking NSAIDs for comorbid condition, they should continue their therapy, those with rheumatoid arthritis or other conditions that require NSAIDs, and that there shouldn't be any difference in the use of antipyretic strategies between patients with or without COVID. That being said, there's some people that they use acetaminophen as their preferred antipyretic agent. And then if the NSAIDs are needed, they try to use the lowest effective dose. Then we've heard a lot about chloroquine and hydroxychloroquine at this point. As you know, chloroquine is an antimalarial that was developed in the 1930s. Hydroxychloroquine was developed, it's an analog of chloroquine with less side effects. It was developed about 10 years afterwards, and it's mainly been used as an immunomodulator in SLE. Its antiviral properties have been studied for years. It's believed that in vitro it increases the endosomal pH, inhibiting the fusion of the virus and the host cell membranes. It inhibits the glycosylation of the cellular ACE2 receptor, which may interfere with the binding of the virus. And so it also may block the transport of the virus from the early endosomes to the endolysosomes, and that will prevent the release of the viral genome. And it's known to have immunomodulatory effects. So based on that, there have been many speculation about this, but hydroxychloroquine with or without azithromycin did not reduce the upper or lower respiratory tract viral loads or demonstrated any clinical efficacy in a rhesus macaque model. And in a large randomized control of hospitalized patients in the UK, it did not decrease 28-day mortality when compared to standard of care. They actually had longer median hospital stay. And among patients who were not on invasive mechanical ventilation at the time of randomization, those that actually received hydroxychloroquine were more likely to subsequently require intubation or die during hospitalization than those who received standard of care. So per the NIH guideline panel, given the lack of benefits seen in randomized controlled trials and the potential toxicity, they recommend against the use of it with or without azithromycin in hospitalized patients with COVID-19. Several randomized controlled trials have been done on the non-hospitalized patient and have not shown any benefits, but there's still trials ongoing. So for the non-hospitalized patients, they recommend against use, except if they're part of these clinical trials they're continuing to study. They recommend against the use of high-dose chloroquine, and they are not approved by the FDA for treatment of COVID-19. And in June of 2020, the FDA revoked its emergency use authorization for patients in severe COVID because of the potential, now the potential risks were higher than the benefit. Azithromycin, again, studies have not suggested an associated clinical benefit. They have been studied with both azithromycin and hydroxychloroquine are associated with QTc prolongation, and the combined use may potentiate these adverse events. So far, no evidence. I see a lot of people out there using azithromycin without any base. So that's all I have to say about that. Then the other hype that has been more in the news lately is ivermectin. So ivermectin is FDA approved for antiparasitic effects, especially for to treat several neglected tropical diseases. So it's widely available and it's cheap. It's used in onchocerciasis, helminthiasis, and scabies, and even in lice. So we have a lot of experience with the use and safety data. Its antiviral properties has been studied for years in different viruses, but mainly they've been seen in vitro. And you can see here the list of all the viruses where it has been studied and has some proven effect in vitro. And it acts by inhibiting these transfer proteins that are in the cytoplasm and transport the virus to the nucleus, and it helps them evade the host immune response. So what it does, it binds there and allows the virus not to be able to bind to those transfer proteins. So it has shown to inhibit replication of SARS-CoV-2 in cell cultures, but the equivalent dose that you will have to use to achieve those plasma concentration, it will have to be 100-fold higher than the approved current dose that we use in humans. So right now is not approved for the treatment of any viral infection, including SARS-CoV-2. And in April 2020, the FDA released a warning of ivermectin intended for use in animals should not be used in humans. There have been several randomized trials and retrospective cohort studies of ivermectin used in patients with COVID-19. Some have been peer and some have non-peer reviewed. Some clinical studies showed no benefits or worsening of the disease after ivermectin, but others have showed some improvement, including shorter time to resolution of disease, greater reduction in inflammatory markers, shorter time to viral clearance, or lower mortality rates in patients who receive ivermectin compared to placebo or a comparative drug. But most of these studies had incomplete information. They have significant methodologic limitations, which make it difficult to exclude a bias. So as of now, the NIH treatment guidelines, they say there's currently there's insufficient data to recommend either for or against the use of ivermectin for treatment of COVID-19. We need high quality clinical trials to provide evidence-based guidance. Then the other treatment that we've used, especially initially when the pandemic started, was convalescent plasma. So that's obtained from individuals who had recovered for COVID-19 to provide passive antibody immunity. And that it's believed that the active component were the neutralizing antibodies, although other immune mediators in the plasma may also contribute. And then Mayo Clinic developed this expanded access program that allowed to provide access for an expanded access for everybody to get convalescent plasma. And it was available through emergency use authorization. So actually over 70,000 patients in the US have received COVID-19 convalescent plasma. But unfortunately, the study of all these patients did not include an untreated control arm. So what they did is retrospectively, they did indirect evaluations of the efficacy, hypothesizing that those that had higher neutralizing antibodies would have a better outcome than those who received the plasma that had lower titers of antibodies. So, and they did find that convalescent plasma with high antibody titers may be more beneficial than those with low titers, especially if you give it to non-intubated patients within the first 72 hours of diagnosis. The problem is that there's no widely available and generally agreed upon best tests for measuring those neutralizing antibodies. And then the antibody titers of plasma from patients who have recovered from COVID is very variable. The other issue is that hospitalized patients with COVID may already have SARS-CoV-2 neutralizing antibodies, and then, it's unclear how much they will benefit from getting more antibodies. So several randomized placebo-controlled trials of convalescent plasma are still ongoing. The same thing right now, there's insufficient data to recommend either for or against the use of COVID-19. in general, it's favored that those with high neutralizing antibody titers, they may benefit when given early in the course. And maybe there's a population specific where we can give this, especially in those individuals with deficits in antibody production, like those who receive anti-CD20 therapies. There's no evidence in severe disease. It is available, as I said, as an emergency use authorization, but it's currently not being used in hospitalized patients outside of clinical trials. And it is being evaluated in outpatient populations with non-severe COVID-19 and as post-exposure prophylaxis. What about vitamin D? Vitamin D, I think we've been talking about vitamin D, many things for many years now. We know that vitamin D is critical for bone and mineral metabolism. Vitamin D receptor is expressed on immune cells such as B cells, T cells, and antigen presenting cells, which also they can produce the active form of vitamin D, which can they have the potential to modulate innate and adaptive immune response. There have been observational studies that low vitamin D levels have been associated with an increased risk of community acquired in older adults and in children. They may increase the supplements of vitamin D may increase levels of T regulatory cells in healthy individuals and in patients with autoimmune disease. In a meta-analysis of randomized controlled trials, vitamin D supplementation was shown to protect against acute respiratory tract infection in general, not specific for COVID. And then there were 2 randomized double-blind placebo-controlled clinical trials where high doses of vitamin D to critical ill patients with vitamin D deficiency, but not COVID-19, did not reduce the length of the hospital stay or the mortality rate when compared to placebo. And there are some side effects of giving high or having high levels of vitamin D if you overdo it. So it may cause hypercalcemia and nephrocalcinosis, although that is a rare complication. The problem with studying vitamin D deficiency in patients with COVID is that vitamin D deficiency, which is common in the US, is more common in the Hispanic ethnicity, Black race, older patients, those with obesity and hypertension, which are basically the same population that is at high risk for COVID. You know, that doesn't mean causation, but it's harder to evaluate without confounding factors. So in patients with COVID-19, vitamin D supplementation may be necessary to meet at least the recommended intake, but doses exceeding the upper level intake are not recommended. Serum levels are reported lower in critical ill ICU patients, more commonly in critical ill patients than in patients on the general medical unit. And small observational studies report an inverse association between mean vitamin D levels and COVID-19 cases. But again, as I said, it's confounded by those common risk factors. So there's no clear evidence that vitamin D supplementation reduces the risk of severity of COVID-19, and the role in preventing or treating is still not known. The rationale is based largely on immunomodulatory effects that could potentially protect against COVID-19 infection or decrease the severity of illness. But there are ongoing observational studies that are evaluating the role of vitamin D, and we will learn more about this. As a side note, I take vitamin D every day, supplement, not an excessive amount. So then we're going to talk about monoclonal antibodies, which at the end of this talk, per Dr. Ramos, we're going to test everybody and how to pronounce these monoclonal antibodies. So these are recombinant neutralizing human monoclonal antibodies that target the receptor binding domain of the spike protein, and so they block the binding of the RBD to the host cell. They are being still evaluated in outpatient with mild to moderate disease, and early trials have suggested some possible benefit. So in November of 2020, FDA issued an emergency use authorization for bamlanivimab, that is from Eli Lilly, and for the combination casirivimab with imdevimab, which is from Regeneron. That's the one Trump God. So from non-hospitalized COVID-19 patients with mild, I'm not advising against either one. I'll show you the data. For non-hospitalized COVID-19 patients with mild to moderate risk factors for severe disease. So the risk factors for adults older than 18 years of age include any of the following: BMI over 35, chronic kidney disease, diabetes, immunosuppression, over 65 years of age, or over 55 years of age who had cardiovascular disease or hypertension or COPD or chronic respiratory disease. It is recommended to be given as soon as possible after a positive test, but no longer than 10 days after the symptom onset. Bamlanivimab is given as a single dose over 60 minutes in a trial of 452 patients. It reduced the risk of hospitalization compared with placebo, 1.6% versus 6%. There's some minor side effects like nausea and infusion-related adverse effects like pruritus, flushing rash, but they were uncommon and mild. And then casirivimab and imdevimab, they're given together as a single infusion. And then in their interim analysis of 275 patients, it reduced the viral load and the rate of medically attended visits during the 29 days after infusion. That being said, the benefits and risk in children are still uncertain. It is approved under emergency use authorization in children older than 12 years of age and weighing over 40 kilos who have mild to moderate illness, are not admitted to the hospital for COVID, and have risk factors. And these are the risk factors that the FDA reported. So BMI over 85 percentile, sickle cell, congenital heart disease, neurodevelopmental disorder, medical related technology dependence, like having trachs, G-tubes, and then chronic respiratory disease that requires daily medication for control. So that was the emergency use authorization by the FDA. But the Pediatric Infectious Disease Society and a group of expert panels, they released this in early January about the guidance of use of monoclonal antibodies in children and adolescents. They proposed that the course of COVID-19 in children and adolescents is typically mild. We still don't have high quality evidence supporting any high risk groups, and there's no evidence of safety and efficacy of monoclonal antibody therapy for treatment of COVID-19 in children or adolescents. So there is limited evidence of modest benefit in adults, and there is evidence of some side effects, including anaphylaxis. So based on this evidence, as of December 2020, they suggest against routine administration of monoclonal antibody in children for the treatment, regardless of those high-risk patients that the FDA proposed. But they will still be looking at the data and update as more evidence becomes available. So then remdesivir. So remdesivir is an IV nucleotide per drug of adenosine analog that binds to the viral RNA-dependent RNA polymerase, inhibiting viral replication through premature termination of RNA transcription. And it has shown in vitro activity against SARS-CoV-2. So here's the normal sequence of the virus. And then here with remdesivir, it blocks the RNA replication. So in macaque models of SARS-CoV-2 infection, remdesivir was initiated soon after they inoculate them. And these animals, the ones treated, had lower virus levels in the lungs and less lung damage than in control animals. Currently, remdesivir is FDA approved for the treatment of COVID-19 in hospitalized adult and pediatric patients over 12 years of age and over 40 kilos. It is available as an emergency use authorization for treatment of COVID-19 in hospitalized pediatric patients less than 12 years, but over 3.5 kilos. And it should always be administered in a hospital or similar setting. So there's been numerous trials in patients with severe. The ACT-1 trial reduced the time to clinical recovery, 10 versus 15 days. The benefit was most apparent in hospitalized patients who only required supplemental oxygen. Among the subset of patients who were on O2 supplementation, but did not require high flow nasal cannula or ventilator support, there was a statistically significant mortality benefit. But there was no observed benefit in those who were already on high flow nasal cannula, non-invasive ventilation, mechanical ventilation, or ECMO, although the study was not powered to detect those differences. There was a trend towards lower 29-day mortality that was not statistically significant. And there was no observed benefits in patients with mild or moderate disease. So it's recommended in hospitalized patients with severe COVID-19, in those with supplemental oxygen but non-mechanical ventilation or ECMO is recommended for 5 days. In patients with mechanical ventilation or ECMO can be given up to 10 days and is not recommended for routine use in patients who do not require oxygen, who are admitted but not require oxygen. In regards to pediatrics, there's again lack of data. It's preferred to other antiviral agents because the data from the randomized controlled trials and case series in adults suggest that it does reduce time to recovery and appears to be well tolerated. If supply limited, you should prioritize for patients with severe rather than those very, very sick, critically ill, because in those, it hasn't really shown evidence of improvement. Again, Pediatric Infectious Disease Society made their recommendations. These were released, I think, in September of 2020. So again, those patients with mild or moderate disease, they just recommend supportive care. For those with severe disease, remdesivir is suggested for all children with COVID-19 unless there are contraindications. And for those with critical, should be considered for all children unless they have a contraindication. Then dexamethasone, most of us are familiar with the recovery trial in the UK that compare hospitalized patients who receive up to 10 days of low dose dexamethasone to those who receive standard of care. And the mortality at 28 days was lower on those that received dexamethasone. The benefit was observing patients who were mechanically ventilated or require supplemental oxygen, but there was no benefit in patients who did not require oxygen. So kind of the opposite of remdesivir. So data from randomized controlled trial overall support the use of glucocorticoids. And there's different meta-analysis that have showed improvement. In the sake of time, I'm not going to go through all of this, but in general, there was reduced in 28-day mortality, and there was not associated with an increased risk of severe adverse events. In children, again, trials are ongoing, and the benefits and risks are uncertain. Pending the results of this trial, administration of glucocorticoids ideally should occur in the context of a clinical trial. For selected children who cannot participate in a clinical trial, if they require mechanical ventilation or supplemental oxygen and have risk factors for severe disease, it may be warranted. And the duration of therapy is up to 10 days or until discharge, whatever is shorter. A few words on remdesivir and baricitinib, which is a Janus kinase inhibitor that has been used in rheumatoid arthritis. It has immunomodulatory effects, and it potentially has some antiviral effects through interference in viral entry. It's in November of 2020, FDA used also an emergency use authorization that when used in combination with remdesivir in patients with COVID-19 requiring O2 or vent support. It appears to modestly improve time to recovery, but there's greater evidence of benefit with dexamethasone. So it will be indicated for like the rare patients who have some contraindication for glucocorticoids and are starting remdesivir. So that's a reasonable approach, but it should always be used with remdesivir. In children, there's an emergency use authorization to be used in patients over 2 years hospitalized with COVID-19, but there's limited information, and it should only be used in context of a clinical trial. Then anticoagulation, and I know people have a lot of questions about this, and even myself, this has been back and forth. So infection with SARS-CoV-2 has been associated with inflammation and prothrombotic state. There's increased fiber degradation products, fibrinogen and D-dimer, and those increased markers have been associated with worse clinical outcomes. There's limited prospective data demonstrating the safety and efficacy of using therapeutic doses of anticoagulants in patients with COVID-19. And I think that's always been the debate whether you should use therapeutic or prophylactic doses. In non-hospitalized patients with COVID, there's no data to support measuring coagulation markers, and then anticoagulants and antiplatelet therapy should not be routinely initiated unless there's other risks. And in hospitalized non-pregnant adults with COVID-19 should receive at least prophylactic dose anticoagulation. And patients with COVID-19 should not routinely be discharged while on VTE prophylaxis unless there's other risk factors. So it seems like VTE prophylaxis is appropriate in all hospitalized medical, surgical, and obstetric patients with COVID-19 unless there's a contraindication, but higher doses may be indicated in critical ill patients. But I'm gonna skip all the way to this, which was just released a week ago at the NIH website, that full dose blood thinners decrease the need for life support and improve outcomes in hospitalized patients with COVID. But this is tricky. So this is a large multi-continent trial that is still going on, that in December, this trial published that routine use of full dose anticoagulation when started in the ICU in critically ill COVID-19 patients was not beneficial and may actually have been harmful in some patients. But this new release showed that when full dose anticoagulation is given to moderately ill patients hospitalized with COVID-19, it reduced the requirement of vital organ support, mechanical ventilation, and there was a trend in possible reduction of mortality. So in children, again, we never have enough data, but we do see in some studies that the children with COVID-19 that are hospitalized may be at increased risk of thrombosis, but there's not a lot of data. The NIH recommends that for hospitalized children with COVID-19, indications should be the same as those with children without COVID-19. But there was a consensus guideline that was published in August of 2020, where they surveyed different pediatric experts on their recommendations, and they summarized their consensus. It was 18 pediatric hematologists with expertise in COVID-19, treating patients all over in different parts of the world. And their consensus was that hospitalized patients for COVID-19 related illness, including MIS, that had D-dimer levels more than 5 times the upper limit of normal values, they recommended prophylaxis, regardless of risk factors. If the D-dimers was not elevated, then they will only recommend it if there were risk factors. For those asymptomatic and had no risk factors, they usually did not recommend it. For those asymptomatics who had multiple risk factors, they did recommend it. But that's where it was a little tricky into defining those risk factors. And these are some of the risk factors that they proposed, but there was no consensus as to how many risk factors had to be. And you know, some consider some risk factors and some others. So there's still debate, and I think it has to be individualized. And then I just want to say a few words about this that was just in the news this week, coming from Spain, plitidepsin. So this is a anti-tumor drug. It's a elongation factor inhibitor that has been approved or has limited clinical approval from treatment of multiple myeloma. It has completed phase 1 and 2 clinical trial. The pharmaceutical is PharmaMar, coming from Spain. And in vitro studies showed that it had 27.5-fold more, it was 27.5-fold more potent than remdesivir against SARS-CoV-2 in vitro with limited toxicity in cell culture. And they had 2 mouse models of SARS-CoV-2 infection where it showed reduction of viral replication in the lungs by 2 orders of magnitude using prophylactic treatment. So they're moving forward, and we'll be hearing, I think, more of this. So in summary, all of these things that I talked about, many of them had no evidence. I think what is clear that patients with mild or moderate disease, unless they have risk factors, and mainly adults, the only recommendation is supportive care. And some may be candidates for monoclonal antibodies. I do want to point out that dexamethasone should not be used. Remember what we talk about, the early and the late stages of disease. Those hospitalized but that do not require supplemental oxygen, they may benefit from remdesivir. Those that require oxygen, the recommendation is remdesivir or remdesivir plus dexamethasone, or at least dexamethasone if remdesivir is not available. And those that are very sick, probably dexamethasone will have more effect, but you may also use remdesivir. So I do want to finish with this. We always feel the need to do something for our patients, but we have to remember that we should go by our first do no harm principle. And sometimes if there's no evidence, it's better just to give supportive care rather than giving treatment that may harm our patients. And with that, I'm going to end.
Thank you so much, Dr. Ramos and Dr. Sanchez-Vegas. I think this is excellent presentation on a topic that's like changing by the day with the guidelines. And thank you for making it comprehensive, but also up to date and evidence-based. We do have, I know we're a little bit over the time, but we'll take maybe a few questions for 5 minutes for those of you who could stay with us. So there's a couple of questions in the chat about pre-medication with Tylenol related to the vaccine, or even after the vaccine for myalgias. And would pre-medication with Tylenol decrease the effectiveness of the vaccine, or would taking ibuprofen is preferable? What's your take on that for the vaccine?
To me?
Anyone? I don't know, either you or Dr. Ramos.
I think that there's some evidence in previous studies in children when you give vaccines that if you pre-medicated with acetaminophen, they had a lower antibody response. So in general, the recommendation is not to pre-medicate before the vaccine. But if you do have symptoms of myalgia, you can take it afterwards. There's no contraindication for it. I will tell you that when I had mine, I had some myalgias with the second dose or some chills, and I did not take anything because I didn't want to touch that immune response. But you can take it afterwards, not preemptively.
I'll tell you the advice that I gave to my son. He called me yesterday that he got the second vaccine and had a lot of arm pain. I said, move the arm, put a little bit of ice on it, and forget about it. You're just developing antibodies, and that's a good thing.
Good advice. Let's see. There's a couple of questions related to sequencing. And is there a way that to have people's individual COVID virus infections sequenced? I know Dr. Ramos had talked about the different variants and the mutations that have been happening.
Right. So the sequencing is great, and there are some virologists that believe that you should do thousands and thousands of viruses, but the only problem is it is expensive. It can only be done by the government or very special institutions. It's not something that is in any way available to us. The World Health Organization does a lot of that. We broke off our relationship last year, so that made a change. We have not done a lot of sequencing. Now they realize how important it is, so we're going to see more of it, but it's not something that is available to us. It's something that is done by public health or by very good, up-to-date laboratories affiliated with universities.
Thank you. One question about how to counsel patient when they are exposed at home and they have received the vaccine. Can the person come to work and when? So an exposure after a vaccine, being vaccinated.
So the problem is the data that we have for efficacy is based on very, very few patients. Even though it's been given to 40 million people, the data after exposure and so forth is very limited. So there's still, at best, a 5% or maybe a 10% chance that person could develop mild COVID and may be able to transmit it. So it would be the same recommendations as anybody who is exposed. I would say probably that person is not going to develop serious COVID or even moderate. Probably if they develop anything, it's going to be mild, but there is a chance for transmission. So it's the same as anybody who's not been vaccinated.
There was a question regarding contact tracing. Have we given up on that in the United States?
Yeah, we did. Unfortunately, we never really started. There was a little bit done initially. We're not doing it. There are countries like South Korea and Japan, and that they have done a great job. We have not, and I think England learned the lesson. They're doing a great job now. They kind of forgot about the whole thing and left it, but now they're doing it. So we're not there yet, unfortunately.
Another question about not including patients that have been treated with plasma. Is there a waiting period other than the recommended 10 to 14 quarantine, I'm assuming 10 to 14 days, to not be infectious prior to receiving the vaccine? I'm assuming it is related to somebody was exposed and
somebody that had received convalescent plasma, or whether or not they should
when they can be immunized.
wait for. I think, I'm not sure, Dr. Ramos, do you remember if there should be delayed in those? Because if they receive antibodies, there may be some blockage of the immune response, but I'm not sure.
There are no, I don't remember that there are specific guidelines for this, but there is a concern that if you have received antibodies, that the vaccine is not going to be effective. In most cases, you probably would want to wait 3 months. But again, I have not seen any specific guidelines, but the concerns are there that the vaccine may not be as effective because it could be blocked by the antibodies that you got.
Similar if you got disease, that some say because people 3 months after they don't develop, the majority don't develop reinfection, that you may wait up to 3 months or 90 days after infection to get the vaccine.
How about children older than 16 years old or adults with Down syndrome or congenital disorders, including autism? Are they able to get the vaccine?
There's no, yeah.
Yes.
The only contraindications for the vaccine is people who have had severe allergic reactions such as anaphylaxis. There's no other contraindication. Even pregnancy, a lot of people have mistaken this. Pregnancy is not a contraindication. They have actually, in the initial trials, there were a lot of women that ended up getting pregnant during the trial, about, I think, 250 or so. And they're being followed very careful, but most people don't see how a messenger RNA vaccine can affect the baby. I think it's perfectly safe.
Are you aware of any oral manifestations for COVID-19? Oral.
Loss of taste is the most common one, but also I did see some evidence or reports of gingivitis and ulcers, but I don't think it's been something that it's been dominant.
One question about any thoughts about the Sputnik, the Russian vaccine, from Dr. Della Volpe.
I think that it will work. I have not seen anything that is as effective as the Pfizer or Moderna vaccine. I think it's going to work. I think different countries have a different situation. For example, China has a very large population. They need to go ahead, and even if their vaccine is only 50% or 40% or whatever it is, they need to go out and immunize as many people as possible, because a very serious outbreak could kill millions and millions of Chinese. And then obviously Russia also has their financial limitations. So this is the vaccine that they have, the one that they developed. It hasn't been studied as well as the ones developed here and in Europe, other European countries. But I think for them, it makes sense to use it in Russia, because a lack of vaccine is very, very serious.
Let's see. There was a question on, I guess, what's the earliest age for children receiving the COVID vaccine now?
So that's going to change very quickly. Pfizer said that they had completed the 12 to 15-year-old, and they did a small amount of patients. They only did 2,000 patients. It is being submitted to the FDA. If they approve it, then we'll be able to start vaccinating people from 12 on.
One question related to masks. I wanted your opinion as to whether the use of masks might have been a selective pressure to the development of more infectious strains.
I don't think so. I think viruses are going to mutate. They do whatever they want. That's why they're viruses, because they do whatever they want. And they're going to mutate whether you wear a mask or you don't wear a mask. Their pressures, their physical pressures, their chemical pressures that cause these mutations, they're very complex and they will happen.
One thing, maybe a word of caution related to your opinion about the people who make the argument that mortality rate is so low so that there shouldn't be too much worry about getting sick, as far as who are maybe vaccine hesitant people who might say, the mortality rate is low, shouldn't be too much.
My answer to that is you shouldn't worry about getting sick unless you get sick or your family members get sick. Then worry about it a lot because, I think I've been involved with over 100 patients that have been sick, and you can't predict it. This is not, you could have a person who is 24 years old, an athlete, a person who runs 10 miles a day, and that person could end up having myocarditis and not be able to do that ever again. And it's happened to professional athletes. There are baseball players, there are basketball players who had excellent careers that now are not as good as before because they got COVID. So stay away from it, get vaccinated.
Related to, I guess, the Johnson & Johnson that's coming up, the vaccine, does it create more immune response? And is it only one vaccination? I know it's a one
Yeah,
dose.
I think it's a very good vaccine. Like I said, in all age groups, it happened to cause about 90% immunity. In the younger age group, which was below 55, 100%. These are small numbers. Johnson & Johnson is supposed to put out their phase 3 studies next week. So it'll be in the New England Journal. Anything that's going to be important and is going to come out is going to be in the New England Journal. We want to see the bigger trials because what we're looking is at phase 1 and 2 studies. Phase 3 studies, they haven't published yet, but I think it's coming next week.
One question about a person who gets the disease after the first dose of the vaccine. So between the first and the second dose, so should they get the second dose?
So there are no official recommendations for that. There are no official, no, they have not addressed that. What I have told them, and that has happened, is get the second vaccine, because if you don't get it now and you wait 3 months, you probably need 2 vaccines. So it depends on whether you want to have 1 shot or 2 shots. I think it's better if you started already, finish the vaccination.
I heard some experts talking about that, and the recommendation is to wait the 14 days that you're not contagious anymore, just because you don't want to go to a vaccine site and spread it to everybody. So just wait your quarantine, even if that delays the vaccine for like a week, or if you're really sick, wait until you're not sick anymore and then go get your second dose.
What about if you have an elderly parent with comorbid conditions, with allergies, but not to the vaccines? Should you vaccinate? There was, I guess, a report in Norway of frail elderly people in nursing home died after vaccination, which probably they might have died anyway, but would you recommend?
So it appears that what happened in Norway is they vaccinated people that were already under hospice. They were very, very old. They were very sick. If you have an older person that is not dying by any means, that has the usual problems of hypertension or heart disease or whatever, but they're functioning, please get them vaccinated.
and then we'll take two more. Going back to what was stated about women getting pregnant during the clinical trials with the vaccine, which company trialed these women? Is it Pfizer, Moderna, or both?
I think both, but the one that I read was, and that information is available. I read with Pfizer that there were well over, I think it was 240 or 250 women who got pregnant. The companies are doing an absolute great job. They're following up on these patients. We're going to have the data. They're 100% honest, so we can look at the results. But again, the people that know a lot more about virology than I do, the real virologists are telling me that messenger RNA affecting a baby, it doesn't sound like it's something real. I would be very surprised if they find any problems.
And the last one, I think probably was answered before, but again, just to double check, if we develop antibody, should we take the second dose? So I'm assuming the person is asking with the first dose, do we need to, if there is antibody, do we get the second dose?
We should, because we don't know how those antibodies are going to last. We should follow manufacturer's recommendation because that is how the studies have been done. We know that probably if you get vaccinated, you're going to be protected at least for about 4 months. One vaccine, the protection may be less than 4 months.
Awesome. Thank you so much. That was great. And thank you for staying. We have almost 100 people stayed to get their questions answered. So obviously it's a very well-needed topic. And thank you for making it so up to date and answering these people's questions. I think you get all these questions all the time. So
Thank you.
Thanks everyone for joining us. Happy weekend. Have a great weekend, and we'll see you next week.
Thank you. Thank you very much.